First, I'm going to introduce Dr. Brett Teran. He's one of our physiatrists at Plymouth Bay Orthopedic Associates. He's a really nice guy. He's a really smart guy. And actually, I've got to know he's actually a really funny guy. So I'm going to turn the podium over to him, let him get his talk going, and then we'll move on from there. Thanks.
Well, welcome, everyone. We're going to start it off in talking about concussion. So a hot topic, certainly. A lot's been in the news lately about this topic. I'm going to bridge the topic first, then obviously go into some of the treatment and management with our other speakers. I think it's best to kind of look at it in the whole and see some of the myths out there about concussion and kind of take care of some of those. So first thing off the bat is a concussion only occurs with a direct blow to the head. This is a myth. I'll describe basically what concussion consists of. It's Latin for concussus, which means to shake violently. It's a direct blow to the head, face, or neck, but it can also be an indirect blow that results in shearing forces across the brain. Force that's delivered to the brain can cause some stretching of the neurons and axons and the complex cascade of that happens. And you can see that pictured over here on the lower right. It is a complex situation which happens when a concussion takes place. So it can be direct or indirect. It doesn't have to be that direct blow. The epidemiology is pretty important. How often and what does this consist of, as has been alluded to before? This is very frequent. We see sports-related concussions happening 1 to 1 million per year in the 0 to 18 range. 400,000 concussions that we know of in high school athletes. And as you see in the bold here, 50% of those concussions are unreported. We've seen recent studies that show that we have seen a decrease in concussions in practices, but an increase in games. Well, what does that mean? Well, certainly we're trying to help some of the training aspects and prevent it during the training that happens for athletes. But we're still having an increase in the games themselves. So it's a very difficult problem to deal with. The sports that are highest risk, football, girls soccer, there's some risk factors that we know of. We're still trying to figure that out as far as the science goes. But previous concussion is a big risk factor. There is one protective risk factor that we've seen with some studies, particularly looking at neck strength. Which we know that has. We don't exactly know how to do that and what type of a rehab that entails, or what we call prehab is before this happens, before an event. But we know that the neck strength can be important. Moving on to pathophysiology of concussion, it is some shearing forces across the brain, as I mentioned, direct or indirect, but it's a functional disturbance that happens rather than a true structural injury. Now, there are those more serious events that happen that are true structural injuries, but majority of that we see is a functional disturbance of the brain, and it's this cascade that happens. And again, it's pictured on the right side of your screen in all of the inner workings of these neurotransmitters. But it's hypermetabolic state. There's free radicals involved, and there's this supply and demand mismatch that happens. And when that happens in the brain, there's tissue vulnerability that happens. And that is the state that we can consider very important. And hence, all of this has been built around precautions and taking players out of games, as you've seen, and assessing them and making sure that they either can or cannot play. But this fear that we have is called second impact syndrome. And that fear is basically that if you have a second event on top of the first, with that vulnerability taking place, there can be serious consequences, and that is edema, brain injury, and death. And we've seen that in a few cases. That's why so much is drilled or so much excitement is moved towards prevention and treatment and early recognition of these things. Next myth to look at is a concussion occurs only when an athlete experiences loss of consciousness. And symptoms of a concussion begin immediately after the injury. Well, you can see here the first answer is on the bottom there. 90% of concussions typically don't have loss of consciousness. And the other part of it is, too, that you can see in a younger athlete, there's actually a delay in the onset of symptoms, which is very difficult because a lot of us, if they're assessed, they don't have any symptoms, they can go back out and play, when in fact, maybe those are a delayed onset. So it's very important to tease out the little things that you can see with athletes. These are listing some symptoms, pretty typical: headache, dizziness, fogginess, as you can see listed. And then I thought it interesting to put up the new language of emojis. And this is a brain institute in Australia that put up the signs and symptoms of concussion in our new language of texting. Assessment, usually it's clinical. We base off a lot of self-reported symptoms. There is no diagnostic test to test concussion. So we use a lot of those symptoms. We use checklists. We use certified tools to help us in grading these symptoms and the severity and tracking them. Things like headache, fogginess, insomnia, lability. And there's actually this concussion recognition tool, which is a tool out there in several governing bodies, which you can see: FIFA, soccer, as well as the Olympics, that use this tool to identify the symptoms and report them. Moving on to examination of concussion, really if it's an emergent injury is what we're really looking for immediately after this event. And that is sorted out on field. Certainly docs and athletic trainers and whoever is there can sort that out. But it consists of a complete neurologic evaluation, including balance and coordination testing. And you can see here two major things that sometimes we don't always think about. We certainly think about headaches and dizziness and fogginess and the loss of consciousness that sometimes occurs. But vestibular and ocular impairment is very high on that list of involvement. And we use something called the VOMS, which is a vestibular ocular motor screening tool, which physical therapists and us as medical providers will use to grade those types of impairments with a concussion. We also use IMPACT. We are all certified. We use this tool. It is a tool that we use to standardize and assess the cognitive and neurocognitive abilities of a person, both before at baseline when people are tested, and it's becoming more and more popular to test, which is great, to have a baseline before an athlete participates in sports, high school, or even younger. And we use this tool to help us grade and figure out the symptoms and whether or not they're recovering. So next quickly is myths about, is it safe for a player to return to the same game or practice after suffering concussion? Well, the answer is possibly, but again, if you're suspecting a concussion, then the answer is no. Recovery from a concussion requires complete rest. Well, that's been a topic of debate as well. Lately, we've seen evidence to support that strict rest isn't always the best. And in fact, it can slow recovery and lead to a chance of prolonged symptoms. So we usually give a period of 24 to 48 hours of symptom-limited cognitive and physical rest, and then gradually increase it. And it's called the Return to Sport program, Return to Play. And that on top of that also is we're dealing with athletes, we're dealing with young people involved in school, and we need to what we call Return to Learn program as well, which is also a graded program to return them back to their usual learning environments and abilities. So that on the right there is just a graded stepwise, maybe that we'll go over in a little bit. I wanted to bring this up because, again, as concussion is pretty complex, the brain is complex, and there is a myriad of symptoms that happen with concussion, and it's so variable, as I mentioned. But there's all of these domains where we have to look into and assess and try to treat. And you can see how all of it comes to play. So not only is it one person, one doc, but also other medical providers, physical therapists, occupational therapists, speech therapists that are involved in all of this treatment. So it really is a team that does this treatment, which is a good thing. And then finally, having one concussion places you at risk for future concussions. This is true. This is fact. We've seen that as a risk factor for concussions, that if you have a previous, you are more prone. And then is a child's brain the same as an adult brain? Well, the answer is no, it's not. And we've seen that as far as the recovery of concussion. Again, excellent prognosis when you talk about concussion improvement overall. 80 to 90% of athletes are symptom-free within 1 to 2 weeks. But for younger kids and adolescents, it takes up to 4 weeks, and this is because the brain, again, is still growing. But there is a stepwise reduction in symptoms, and we try to support that and help that in those tools that we use. And just mentioning a few other things that can be difficult to deal with when you recover somebody from a concussion or event, and that is their history and possibly a prolonged syndrome called post-concussion syndrome. Chronic traumatic encephalopathy, or CTE, I just need to bring that up. It's certainly out there in the news and literature. And just to go over that quickly, is concussion related to CTE? We don't know the answer to that. We know that there is some relationship, but it's not quite clear. We know that CTE is a tau protein deposit. That's what happens physiologically. But is it a cause or a byproduct? We don't know. It strongly could be correlated, as you see in the imaging there. It looks a lot like Alzheimer's dementia, as on the right, compared to a control. But what we think is happening is repetitive subclinical impacts. So not necessarily are they having concussion events, but they're getting repetitive subclinical impacts that are happening. And there's a lot of other risk factors we haven't sorted out. Just a word on the law and prevention. 2009, there was a concussion bill that really stimulated the rest of the states to come along and put this out there, which is when in doubt, sit them out. So when we know that an athlete is injured or has a suspected concussion, they should be removed immediately from the game. And that's been seen all through the other states. So a few things on prevention: delayed onset of body checking, tackling and technique in soccer, newer helmets are things that we can hopefully use to prevent concussions. But these are early studies, I would say. We've tried to start to change the environment around practice. But we know from using helmets that sometimes that can be a detriment, and it can actually make people want to be more aggressive because their equipment is hopefully better. And then finally, just a quick word before I switch over. Emerging tools and therapies out there. This is a list of things, but there are things out there like apps that help us assess people on the field, or in the event. Impact monitors to help us research these things. Some things that deal with neural inflammation are out there and potentially have an effect, but we don't know yet. There's just animal studies. Some clinical markers that we use to try to track concussion or potentially stop from using so much imaging on concussion, which can't always be specific for the events. And then 2 treatments out there in trial, which is stimulation, magnetic stimulation, and potentially intranasal neurosteroids. So that's what I have. Thank you.
Dr. Teran mentioned Impact. I don't know how many of you have heard of that. It's a company that's sort of the gold standard on concussion, and they put out a lot of information and research on it. We have at Plymouth Bay Orthopedic Associates the only facility in the state that's credentialed to be able to sort of take concussion from the day one to return to field. We're able to interpret the neurocognitive baseline tests that Dr. Teran mentioned. We have the rehab specialization, and we even have a pediatric specialization on board. And I'm pretty sure that as of last check, there's no other place in the state that has that. So we're pretty proud of that.